fully booked, 250 people that we expect today from more than 30 countries. We realized that the knowledge of fluids is a big problem. Lots of doctors make big errors in prescriptions, giving too much, giving the wrong fluids. So we wanted to organize this Congress to make a clear statement what to do and unravel all the mysteries that are going on.
We are happy that we had the most important top specialists of today on fluid management and hemodynamic monitoring. We have speakers from England, the Netherlands, France, Germany, even Israel.
I'm very proud to be part of the first telemedicine unit in Europe.
My name is Paul Albers from Amsterdam, the Netherlands. I've been talking about saline-induced metabolic acidosis, and I think the Stewart approach really makes it easy to understand why this is a real phenomenon that may cause harm in many patients in which every detail is critical. So I would say think twice before using saline.
I'm Jan Bakker from the Erasmus Medical Center in Rotterdam, and I'm talking about lactate and fluid resuscitation. For my presentation, it's clear that fluid resuscitation is associated with severe decreases in lactate levels in the early phase in critically ill patients. And especially in surgical patients, prevention of increases in lactate in the normal range are very good to prevent multiple organ failure and death in these patients.
My name is Sibylle Kotzek. I come from Vienna, Austria. I'm an anesthetist, and one of my favorite subjects is the potential side effect of colloids and crystalloids on dilutional coagulopathy and clinical outcome parameters such as blood loss and transfusion requirements. In my lecture, I tried to explain why the choice matters, the choice on the selection of the colloid, on the timing and the dosing, and it was a clear superiority in the evidence that we have on hand right now for the use of 6% iso-oncotic tetrastarch versus gelatin.
There are some studies that demonstrated that albumin could be better in cirrhosis patients, and albumin is better regarding kidney function. I'm Eric Hoste, I'm from the Ghent University Hospital in Belgium, and I was asked the question whether colloids or crystalloids are superior for volume replacement in ICU patients. Colloids are not superior to crystalloids. They cost more and they have more side effects. However, in some subgroups of patients, for instance in severe sepsis or in cardiac surgery or in cirrhosis, colloids seem to be better compared to crystalloids. So we need to look into that a bit more deeper.
I'm Jules Wendon from King's College Hospital in London. I was talking today about the role of albumin. Albumin seems to have a significant benefit in terms of management of patients with liver disease. Essentially, there are different roles for albumin. It has a role in liver disease without question, particularly in prevention of hepatorenal failure. More interestingly, it also has a marked inflammatory and anti-inflammatory capacity. And I think increasingly we will see a role for albumin in sepsis, where it seems to have a benefitive effect in terms of outcome and mortality on meta-analyses looking at immune function.
I gave a talk about fluid management and avoiding fluid overload. If you give too much fluids and the patient gets peripheral edema, that is not a cosmetic issue, but it's bad medicine. We must avoid that.
My name is Xavier Monet. I'm working in Bicêtre Hospital in Paris, and my talk was about the monitoring devices that are today available in the ICU and the operating room. And the main message was that during the last year, many technological improvements allowed the development of several monitoring devices that allow assessing the cardiovascular function, and this gives us the opportunity to choose the right monitoring tool depending upon the patient's severity.
My name is Michael Bauer from Jena in Germany, and I'm interested in dye dilution techniques. Why? In the past we have been trying to maximize blood flow to the tissues with all inherent side effects. I guess it's time for a paradigm shift. We need to match blood flow to the demand, and I guess dye dilution techniques can help us to achieve this goal.
The lower the strong iron difference, the lower the pH will be and the more acidotic the patient will become. In my lecture I tried to state that not all crystalloids are the same. You have to balance them to improve them. Not all colloids are the same, and these days we know that the last generation starches are perfectly acceptable and safe, so fluid management, just make a choice, not chance.
I'm Jean-Louis Vincent. I am a professor of intensive care medicine at the University of Brussels. My talk was on fluid responsiveness. How could we predict the patient's response to fluid administration using indices like pulse pressure variation or stroke volume variation? There are limitations to this approach, especially the patients must be sedated and they shouldn't be major arrhythmias. So that in many cases we still have to give fluids, but we could apply a fluid challenge approach using the Troll mnemonic, Troll type of fluids or rate of infusion, O objectives, and L limits. Ultimately, we often have to try and evaluate the patient's response to fluids.
I'm looking forward to a small volume hypertonic solution with a colloid that is charged. Charged so you can diminish the chloride and you can also increase the capacity to keep the water and to hold the water in the intravascular space.
I'm Dr. Hempe, cardiac anesthesiologist at the Middelheim General Hospital here from the ZNA. Sometimes you can use a high concentrated salt solution to attract water from spaces in somebody's body that are on the wrong place. And so you can displace water to the right place using hypertonic solutions being very salty solutions. And that was the essence of my talk.
My name is Professor Azrael Perel. I come from Tel Aviv. I gave a talk today about how to best evaluate the parameters that we have on our monitors. We have a lot of parameters, and some of them are quite inaccurate, so I tried to put some sense and suggest ways how to deal with these inaccuracies and get the correct medical decisions in view of disinformation.
My name is John Inja. I'm a physiologist. I work in the Academic Medical Center and Erasmus Medical Center as a physiologist. My interest in fluids emanates from its impact on the tissues next to the organs. And what we have found is that fluids are very poor oxygen carriers and not very effective in transporting oxygen. They also cause inflammation and oxidative stress. For this reason, new generation of fluids will need to be developed which take into consideration oxidative stress, inflammation, and promote oxygen transport to the tissues of the organs.
Does everyone has a voting band? Okay. We have an interactive voting system, so we will ask questions after each talk to see if there is a learning curve. Which statement is correct regarding hypoplasmatic perfusion? You can vote. Fantastic. Also here, a nice learning curve, 64 to 90%.
We don't want to deliver lecture after lecture. We want to keep the people alive and awake.
And now, ladies and gentlemen, the first prize award certificate goes to number 130 with 63 points. I would like to thank all the speakers, and I would like you, the audience, for coming to Antwerp and for joining us for today. Thank you very much. We hope to see you next year. Cheers.
Hope to see you next year. Cheers.